I'm one of the second-year pediatric residents. I will be talking about my project looking at pediatric solid organ transplant recipients and their strong humoral and cell-mediated response to the mRNA SARS-CoV-2 vaccine. So just for some background, the solid organ transplant recipients were not included in the vaccine efficacy studies, but definitely are at risk for severe disease from COVID-19 due to their immunocompromised status. Most of the studies that have looked in the transplant population have been in adults and have often shown suboptimal immunogenicity, and very few have looked at both the humoral and cell-mediated immunity, which was an important finding that we wanted to look at in terms of the long-term implications for cell-mediated immunity on preserving the immune response. So our study is the first to look at both of these immune responses in the pediatric transplant population, and we're hoping that this information will help us better understand patients' immune response to vaccination so that we can help better protect them from disease. Our patient population included 12 to 25-year-olds who were solid organ transplant recipients and had gotten 2 doses of mRNA vaccine. And from their serum samples, we looked at SARS-CoV-2 specific IgG, along with ACE2 receptor binding domain antibody, which has been shown to be a predictor of severity of disease and thought to be a correlate of neutralizing activity in the body. And then we also looked at the specific T-cell response using an IGRA test, which was an in-house Stanford lab test that has also been shown to distinguish between those who were infected or vaccinated and those who were uninfected. So overall, we had 38 participants with a breakdown of 16 liver, 11 kidney, 7 heart, 2 lung, and 2 liver intestine patients. And when we looked at the overall IgG and IgRA responses, 78.9% were positive for IgG and 66.7% were positive for IgRA, which was really great to see. This table kind of shows the breakdown when we looked at different factors associated with the IgG response. So as you can see, the tacrolimus level, the type of transplant, and the time since transplant were all significantly associated with the IgG response, with the general trend that the higher the tacrolimus level, the more likely they were to have a negative response. For type of transplant, liver transplant had the best chance of having a positive response, as all of them did show a positive response. And then time since transplant, we saw that the farther patients were from their time of transplant, the more likely they were to have a positive response. So our next analyses looked at the anti-RBD antibody response and the IgRA response. So first we looked at these responses by organ type. So on the left, we have the anti-RBD box plots that didn't show a significant difference between these organ types, but did show a general trend that the liver transplant patients seemed to have a higher anti-RBD antibody value, which we hypothesized could be related to the fact that they tend to get transplants younger in life, and so they may be farther out from their transplant when they got vaccinated, and they also may be on less immunocompromising medication regimens. And then on the right, we have the response to the IGRA test, and we did not see a significant difference by organ type. And interestingly, we saw across most of our analyses that the IGRA response did not significantly differ by the different variables that we looked at. Next, we looked at the effect of different medication regimens. So looking at both the tacrolimus level and then the inclusion of anti-metabolite or MMF therapy. So on the left, we have the anti-RBD on the top and the IGRA on the bottom that are stratified by the level of tacrolimus. And so both of these are not quite significant, but are approaching significance, with the general trend that the higher the tacrolimus level, the lower the anti-RBD and IgRA response, which was similar to what we had seen in our the table a couple slides ago with the IgG response. And then we also looked on the right at the anti-metabolite therapy, because in previous studies in adults, they had seen that anti-metabolite therapy did decrease immune response. But interestingly, for our population, the inclusion of MMF with tacrolimus versus just tacrolimus did not impact the anti-RBD or the IGRA response. And then lastly, we were really glad to be able to look in a small subset of 6 patients at the response after the 3rd dose. So we were able to compare their pre and post 3rd dose samples. And on the left, you can see that the anti-RBD value did significantly increase after the 3rd dose, which was really great to see. The studies looking at the 3rd dose for the immunocompromised patients were done in adults. So this was nice to be able to see that in the pediatric population, we saw similar findings of improved immune response. And then on the right, we have the IGRA response that similar to the other analyses did not show a significant increase in IGRA response based on the 3rd dose. So overall conclusions are that the COVID vaccines are effective in this population, regardless of anti-metabolite therapy. And we were really glad to see the pretty significant IgG and IGRA responses across all our patients. We also saw that liver transplant patients did seem to respond better than other organ types for the reasons that I mentioned previously. And then, as I mentioned as well, the improved immune response after the 3rd dose was really great to see. And hopefully with additional patients in the future, we'll be able to look more into that response. And then next steps for our study hopefully are to enroll children under 12 once the vaccine is approved for them. And then looking at the durability of the immune response by looking at these same labs as patients get farther out from the vaccine to see whether or not there's any waning immunity. And then also hopefully further looking into clinical outcomes associated with these immune correlates to see what really is associated with protection. And then I would just like to acknowledge Dr. Nadampally, who is the PI and my mentor for this project. And then Dr. Gans, Dr. Chen, and Catherine Sear have also been helping us on our project, along with all the transplant teams and coordinators who have been helping with identifying patients for enrollment and helping us with lab studies.
Great, thank you, Dr. Bratic. That was wonderful. I think it's a really interesting data for those of us that take care of pediatric solid organ transplant patients. And I also think really reassuring, and especially for somebody who takes care of lung transplant patients who are highly immunosuppressed. It's nice to hear. I was wondering what, with the recent positive news about the vaccine being extended down to 5 years, how do you think the younger patients will respond, or do you expect any difference in that kind of 5 to 12 age group?
Yeah, I think one of the things that we had seen with our study is that a lot of our patients were farther out from transplant. We did have, I think, 5 or 6 who were within the first year, but for the most part, they were pretty far out. So I think one thing that could be possible is that with the younger patients, they may be on higher, more immunocompromising regimens, and they may be closer to transplant, so they may be less likely to respond. But hopefully, as patients start getting vaccines, we'll be able to include them in our study and see.
Sure, it's exciting. And one more question from the audience was, did any of the patients that received vaccination show signs of graft rejection afterwards?
That is not something that we specifically looked at, like it wasn't included in our outcomes, but nothing to my knowledge when I was doing the chart review. But I would also defer to Dr. Nadampally in terms of if she had heard anything specific, but nothing that I had heard of or that we had seen.